So the first talk of the session is by none other than Dr. Gangadhar Sundar sir, who is heading the Department of Oculoplasty and Orbital Facial Surgery at NUH Singapore. And sir needs no introduction. And he has been an authority in oculofacial trauma, and he is a well-known international faculty conducting so many international instruction courses on trauma all around the globe. So sir will be speaking on imaging in orbitofacial fractures, and we'd like to hear about it from you, sir. Over to you.
Thank you, Maya, and it's great to be back in India, this time in Kolkata. My only complaint is so far I've not been fed any mishti doi, so I'm looking forward to it in Kolkata. So those of you from Kolkata, you know now how to take care of me. So this is the first talk where I'm giving in a trauma session where imaging precedes clinical assessment, so on and so forth, and I'll try to do justice in the next 10 to 12 minutes or so. And this talk is going to be focusing purely on imaging. There's going to be another trauma session, I think, tomorrow, where we'll talk about some more recent advances and how we apply, including pitfalls of imaging itself. These are my disclosures. But there are a lot of these chapters that I've written exclusively on imaging and orbitofacial trauma, including the latest book by Dr. Guy Ben-Simon, and I'm happy to share a PDF copy of imaging in various traumatic situations. As long as wars exist, we're going to see trauma. And if you say in India there's no war, there's no war going on except in the border front, that's not true, because there's war going on in every school, every college, every university, every street, every factory. In other words, there's trauma everywhere. And there's a famous saying from the Second World War that war is the only proper training ground for a surgeon. And the take-home message is for leading institutions and leaders of institutions. If you train your trauma residents and fellows and residents well in trauma management, every other elective surgery management will become much better. And from that point of view, reading the scans that you request, not order, is very important. So why do we do imaging? We do it to confirm a diagnosis, this presumptive diagnosis. Apart from knowing that there was a fracture, you want to know the degree of displacement. We'll talk about how that plays a role in management. There are significant medico-legal implications, both at the work site, road traffic, factory, so on and so forth. And finally, we use a technology we use from the various forms of imaging, not just the films that patients bring, but the DICOM data, which is useful. For all practical purposes, CT scan is the imaging modality of choice. X-rays are out. The only reason for doing an X-ray is to screen for any metallic or radio-opaque foreign bodies prior to doing an MRI. And CT scan is not any old-fashioned CT scan. It's now done with an IGS protocol, Image Guidance Surgery Protocol, which has sub-millimeter cuts, 0.625 millimeter cuts, which are acquired in the axial format and then subsequently reformatted in the sagittal and coronal planes, which we look through your PACS viewer, not through your films, because films are compromised because of the number of sections they would do, and then finally you end up managing. What are we really looking for in scans is the placement of the rim, whether it's broken or not, the apex of the orbit, superior orbital fissure and the optic canal, and everything else in between. These two stars highlight the anterior, middle, and the posterior part of the floor of the orbit, which kind of tells you where in the orbit, anterior third of the orbit, middle third of the orbit, or posterior third of the orbit, is where the fracture is based on how you're going to be managing these patients. Traditional textbook talk about the floor as a straight line. It's not a straight line. This, and again, is something that you're looking for in scans. And when you do in the sagittal, you can see the image below. You're looking for the posterior ledge, and that is important because that's the ledge on which you're going to be placing your implant. So again, role of imaging and you seeing your CT scan, and we do not read reports. We read the scans ourselves. We also define this angle between the floor and the medial wall, what we call as the angle of inferomedial orbital strut. Perfect AIOS for AOS here. I think that was a keynote last year. So take that away. Raghu presented this at the ASOP press meeting. And we talked about this angle. And when you're talking about restoration of orbit of a combined floor medial wall fracture on one side, you measure this angle in your DICOM data, in your films, even using a protractor. That's how I started off. You pre-bend your implant, and then you replace the implant in the proper way, with or without navigation. You get good results. So this is literally Raghu over here? No, Raghu is there. So he literally plotted these images when we presented it over there. So these are all clinical applications of patients who have a floor or a medial floor and floor fracture. We are pre-bending an implant. We are not doing intraorbital manipulation, and you get good anatomical restoration of these patients, and it can validate it. So how do you read a scan? So reading scans and surgery is like religion. They're rituals, and you do not question the rituals. You do it a particular way because Dr. Santosh said it so, Dr. Usha said it so, Dr. Ashok Grover said it so, okay? You follow that. You don't cut corners and jump the hoop and just go on to managing the patients itself. So learn to be a student of the normal. So that's why when a patient is injured on one side, don't look at the scan on the affected side alone. Go to the normal side because there are numerous variations itself. So by default, we look at scans. You can see the scan bottom left over here looks like a medial wall fracture. I don't know if anybody else sees anything else. In the bottom left image, there's a straight line in the orbit. Remember, the human body does not have any straight lines. And anytime you see a straight line, there's probably something inside there. That's a Medpor implant inside the orbit, which sometimes are even missed by radiologists and ophthalmologists and orbital surgeons, believe it or not, okay? And these are all examples what you see. Here's a video which plays where we do a CT face and orbits. It's not just CT orbits that we do. Start off with the mandible, work your way up towards the maxilla. Remember, maxilla forms the floor of the orbit. You can see the disruption right over there. And the maxillary anterior wall and the lateral wall is broken. You can see the infraorbital canal is being broken over there. And the lateral part of the maxilla articulates with the zygoma. You can see the zygomatic arch broken. You can see the spheno-zygomatic bone suture also being displaced. Medial wall in this place is intact. Go down to the optic canal, and then you look at it. Likewise, once you review the axial scan, you want to look at the coronal scan. Remember, the nasal bone is the most common bone to be broken, following which is a typical ZMC fracture. Here's a typical ZMC fracture. You can see the disruption of the articulation of the frontozygomatic and the zygomatic-maxillary suture involved. And then if you go further behind, the zygomatic arch is also involved. Again, you want to be able to study all the way to front to back. And finally, the sagittal cut. That gives you the length of extent of the floor, which is most common, and sometimes a roof. And that gives you, you can see the slight convexity of the posterior bulge, infraorbital nerve running down along within the sinus itself. And then when you go to the other side, here I am pausing at the nasolacrimal duct over here, which sometimes also is broken, and you want to look at it. And then you go to the opposite side. So learn to be a student of the normal. See the normal scan first before you go to the abnormal side. And here you can see the disruption of the floor. You can see the palatine bone, which is the posterior ledge. That tells you the degree of displacement. It tells you how far from the rim the fracture ends. So then you can pre-bend your implant, pre-place your implant, and reconstruct the orbit. So reading the scan is extremely important before you go ahead evaluating and repairing these patients. So also important to keep in mind is, yes, when there's an optical, obvious disruption of the cortical bone, it's very easy to diagnose a fracture. So you are all not just ophthalmologists. We are not ophthalmologists. We are orbital surgeons. We are slightly different species. I think that's what Fairuz is trying to tell us all, right? Ophthalmologists are different, orbital surgeons are different. We are different animal species. So you have to be held to a higher standard. You want to pick up the subtle signs of fractures, pneumo-orbit, air in the orbit, air in the anterior skull base and cranial fossa. These are all signs as a disruption of the frontal sinus, ethmoid sinus, maxillary sinuses. Distortion of extraocular muscles. These are all subtle signs because with very minimal displacement, you should be able to pick up fractures. So with all this basis, we came up with a practical classification of fractures along with patient-specific modifiers, a lot based on radiology. So we classified fractures into simple or pure orbital fractures, which is what we all manage. But sadly, this accounts for only 20 to 25% of all orbital fractures. 75% of orbital fractures are complex fractures, which involves the ZMCs, the NOEs, the Lefort 2 and Lefort 3 type fractures, the cranio-orbital fractures, the skull-base fractures, and finally the rare panfacial fractures, everything from top to bottom. You have to have a classification. Without classification, you cannot plan your management. You cannot decide whether you're going to fix it alone or with your craniomaxillofacial surgeon, with or without a neurosurgeon standby, and so on and so forth, okay? So that's where the classification comes in, and that's all based on scans. So here's an example of a pure internal medial wall floor fracture right over here with herniation of contents. Remember, it's not entrapment. Entrapment is a clinical sign. Herniation is a radiological sign, as opposed to a complex fracture you can see on the image right, where you obviously a neurosurgeon has to be involved in addition to you when you're going to refix the orbits. Examples are two forms of blowout fractures. Remember, floor is the most common, but you can see the combined floor and medial wall fractures, which is far more challenges. In fact, most surgeons, even expert surgeons, have great pitfalls in managing a combined flow and medial wall fractures. That's why the AIOS came in. The second most common fracture of the facial skeleton, the ZMC fractures. Again, I have ophthalmologists who come and tell me, my cousin broke his face, he's got a ZMC fracture, but no ophthalmic involvement. How is that possible? Unless you have an isolated zygomatic arch fracture. So all ZMC fractures involving the body involve the orbit, and I think we should be involved in managing these patients. Here's an example of a patient, right? You can see literally a shattered orbit, and it's not just a shattered orbit, shattered soft tissue, but it's no point putting the lacerations alone together, but you bring your sequential approach, roof, lateral wall, inferior rim, then the floor and the medial wall reconstruction based on the reading of the scans. You get your zygoma right. Once you get the zygoma right, you get the inferior rim right, then you pre-bend your titanium plate or whatever plate, PSI, whatever you want, and then you do a soft tissue reconstruction, you can get good results. A quick take-home message in the next minute or so about nasoethmoidal fractures. Again, this is relevant to ophthalmologists because the NLD is involved in 7 to 15% of mid-facial fractures. So again, you want to be proactive about it rather than wait for a dacryocystitis and do a DCR. With all the hardware there, we do prophylactic intubation for these patients. And finally, cranioorbital and panfacial fractures, where we sequence reconstruction itself. So I'll just quickly move on to the last couple of slides about postoperative imaging of orbital fractures. These are implants right over there. These are examples of lacrimal system involvement. Again, you do not want to be the person just looking at the floor, medial wall, lateral wall, and the apex of the orbit. You want to look at the disruption of the lacrimal drainage system, do prophylactic intubation. Traumatic optic neuropathy, as you know, again, is a clinical diagnosis, not a radiological diagnosis. And finally, stop with this postoperative imaging of fractures. Which refractive surgeons offer refractive surgery and does not do a postoperative refraction? If you do a refractive cataract surgery, multifocal lenses, premium lenses, who does not do a postoperative refraction? Why are we ophthalmologists sticking implants inside the orbit, hoping it's in the right place, thinking it's in the right place, and actually they don't want to see the implant in the wrong place. So get into the habit of doing postoperative imaging of orbital fractures, and I think I'll stop right there and go on to more recent advances in Dr. Grover's course, which is going to be held tomorrow. Thank you very much.
Thank you so much, Dr. Ganga, for that elaborated talk, and definitely understanding the imaging plays a very crucial role before planning your orbital reconstruction. And we'll have the panel discussion towards the end of the session when all the aspects of the